Thank you very much. I was absolutely, completely flattered to be shortlisted for the award and forgot completely about it. And when I opened my email from Maria to find that I'd won, I was quite flabbergasted. In fact, I didn't believe it. And I actually emailed back and said, "Oh, you've got the right person." But she assures me, yes, it was. So I'm very pleased to be with you here today. And what I hope I'm going to do is give you some perspective and hopefully amuse you as well. A bit of education and perspective. So because I was coming to a Scandinavian country, of course, I have to give a saga, because of course it's all sagas in this part of the world. And really, the whole saga of cardiovascular disease has been quite dramatic over the course of the last 60-odd years, more than 60 years, in fact. And it's really about the translation of fundamental research into routine clinical practice. And it really has been a revolution, as I hope you'll agree when I've finished. So we're going to start at the beginning. That's always a good place to start. Then we'll consider the question of enter the biomarkers in true Bruce Lee style, but I won't do any actions. And then the question of the times they are changing, and so did the biomarkers. So, in the beginning, there was death. Because in the beginning, you have had a heart attack. Now you must come with me. Because it was considered in the 1800s that coronary thrombosis was uniformly fatal. It was a medical curiosity. Animal experiments were done. If you ligated a coronary artery, the animal died. We don't do this with people, you understand. And post-mortem studies showed that there was coronary thrombosis, but it was considered to be, well, just something that happened. And at the time, if you had a heart attack, you died. That was it. And then quite remarkably, it wasn't till 1912 that James Herrick actually described the clinical features of acute myocardial infarction, differentiated it from angina, and showed that this was not actually a fatal condition. So this was really a transformation. The sun came out. We had a chance to do something for people with ischemic heart disease. This is just a reproduction of the original article published in the Journal of the American Medical Association in 1912, describing the clinical features of sudden obstruction of the coronary arteries and actually saying this is not fatal. You do not immediately die. And interestingly, at that time, Herrick made what would prove to be a very prophetic statement. The hope for the damaged myocardium lies in the direction of securing a supply of blood through friendly neighboring vessels so as to restore as far as possible its functional integrity. And when you consider what has happened over the last 30 years, this really is an extremely percipient suggestion. Then basically everything went quiet for 74 years. There was a lot of medical argument about whether thrombus did or didn't matter. And treatment was quite straightforward. You put the patient to bed, you mobilized them judiciously, and you gave them lifestyle advice. And lifestyle advice at that time, and this was still true when I was a house officer, was that you got up, you exercised gently, you had no conjugal relationships with your spouse for 6 weeks, and no conjugal relationships with your mistress or lover for 8 weeks, because they're much more exciting. And that was it. That's what we told people. There were no therapeutic advances. The only thing that happened was Desmond Julian, while he was a registrar, wrote a letter to the Lancet suggesting that we should put all the people with an MI into one specialist ward where we could resuscitate them if they had ventricular fibrillation. And that halved the mortality from 30% to 15%. Quite dramatic. A few centres in the United States were catheterizing and doing intracoronary thrombolysis, but this was considered to be largely a research test and really didn't have widespread application in the routine. So what was going on in terms of diagnostic testing at the same time? Enter the biomarkers. Well, of course, we have the electrocardiogram, first developed by William Einthoven, for which he won the Nobel Prize in 1924. First studied by Thomas Lewis in the UK in 1912, 2 publications in the Lancet. And he was one of the first people to document the use of the ECG for diagnosis, concentrating to a certain extent on diagnosis of MI, but much more for arrhythmia. But the ECG has stood the test of time. We use it now. It's integral to our first assessment of the patient presenting with chest pain. The ECG decides immediately which management strategy you go back down, and that is on all the current guidelines. What about lab testing? Well, lab testing was there. 1916, Lippmann demonstrated an increased white count after myocardial infarction. This was one of the actual first tests used to differentiate it. An increased ESR was demonstrated by Shirk in 1933. And one thing that I find really very amusing, that the use of CRP in the diagnosis of ischemic heart disease was first published in 1957. So all the talks about CRP, you know, wonderful how good it is. Yeah, but it goes back a long way. However, diagnostic testing in terms of laboratory testing for cardiac biomarkers, really it was 1954 we had the 2 key events from my perspective. The first one, of course, is Arthur Carman publishing the measurement of transaminase activities in human blood as a test for acute myocardial infarction. And this chap appeared. You might recognize the resemblance from the lack of hair. So we have Arthur Carman publishing initially with Ledoux and Roblensky in Science, and then on his own behalf in Jekyll Invest, really describing the first methods for measurement of AST. And in fact, they developed their method and they actually only measured 2 patients. So that was the basis of AST, 2 patients. And the method itself required an 18-hour incubation, followed by an electrophoretic separation and staining with ninhydrin. So this is clearly applicable as a point-of-care test. So obviously they needed to go on and develop, and they then developed a spectrophometric method. Lactic dehydrogenase then appeared, Roblensky and Ledoux in 1955. Isoenzymes of LD appeared thereafter, Byrne and Vessel. And then in 1960, Sidney Rizalki, I would describe as my mentor, first published the use of hydroxybutyrate dehydrogenase by using oxybutyrate as the substrate for measurement, which means that you could very conveniently measure LD1 activity. So this was the first. So we're moving on. We've now got AST and LDH or HBD. And then finally, it was noted that creatine kinase was elevated in muscle disease. And then this was then studied in AMI, published by the French, pleased to say, in French, by the way. So if you want to read the original, you have to brush up on your scientific French. But interestingly, the first practical method was developed by Sidney Rizalki, based on a method originally described by Kornberg, and was the first practical method. And this paper actually is one of the most quoted papers ever in the literature. And then Robert Roberts in the US developed and demonstrated isoenzymes of creatine kinase. So we now have essentially the holy trinity of cardiac biomarkers as it was, AST, CK, and LD/HBD. This is Sidney Rizalki. He demonstrated the prospective methodology for CK over dinner at a restaurant called L'Épée d'Or. And here you can see in detail, and this is just the standard thing, creatine phosphokinase, acts on ADP, and you can see the standard link reaction, which of course is the one we use today. So which only goes to show that you can actually invent things over dinner. And finally, of course, we have the arrival of the definition of acute myocardial infarction by the WHO, including and or unequivocal enzyme changes, possible acute myocardial infarction, serial equivocal enzyme changes with or without equivocal enzyme changes. So we made it. Cardiac biomarkers are official. So here we have the timeline of cardiac biomarkers until the end of the 70s, really. We moved through from AST through the WHO criteria of AMI. And of course we have sex. It was a male disease. Drugs, but we didn't have them for MI. And we had rock and roll, but you had to be there. So now, there we are. But it's time for a change. The 1980s were a decade of change in cardiovascular disease, because at St. George's Hospital, a pathologist changed the world. But it wasn't me. Michael Davis, who sadly died of pancreatic cancer and whose name is acknowledged in the ESC Davis lecture, first described the intramyocardial platelet aggregation in patients with unstable angina. He carried out a whole series of meticulous post-mortems in patients who'd had cardiac sudden death, suspected cardiac sudden death. And this was a transformatory paper, because he was able to demonstrate quite unequivocally the presence of plaque rupture and intravascular thrombus. And you have to appreciate that up until this point, there had been bitter arguments amongst cardiologists as to the pathophysiology of acute coronary syndromes and whether the thrombus did or didn't matter. And this was a paradigm shift in the understanding of the pathophysiology of acute coronary syndromes. And this picture you will be completely familiar with, but this picture did not exist before. The concept of slow plaque accumulation and plaque rupture as the final endpoint was completely new. And so we have the post-mortem example here. Here we have a ruptured plaque, and here we have the intravascular thrombus. And because of this, we then actually get treatment for acute coronary syndromes, which we never had before. 74 years, no change. Acute plaque rupture is accepted as the cause of acute coronary disease. We get understanding of the progression of coronary syndrome, which is why we now have preventive cardiology, which is my clinical field. We have the concept of white thrombus, platelet thrombus, going on to red thrombus, so we then have the logical rationale for antiplatelet therapy and thrombolytic therapy. And we also then begin to get acceptance of the role of acute diagnosis in acute coronary syndromes. Because if you can't treat it, there's no point diagnosing it quickly. And so if we look at the landmark trials that were published, really, we start with the Italians in the Gissi study, intravenous thrombolysis versus no treatment. We then have the ISIS-2 study showing the benefits of aspirin plus intravenous thrombolysis. And the great thing about this is you could do it anywhere, in any hospital, anywhere throughout that had access to a thrombolytic drug. And this again was a transformation. And in fact, people started doing it in ambulances. And it made a tremendous difference in mortality, a halving of mortality. We then move on to the concept of doing acute angioplasty, which of course is now the accepted treatment of choice. And we moved on from streptokinase to tissue plasminogen activator. So this was a tremendous change and improvement. So what's happening with the biomarkers? This is where my life begins, because the biomarkers were changing. And like many events in life, it started in a bar. So there I am in the bar. In comes the registrar of cardiology. We're having a drink, and he says to me, "You're a clinical biochemist. Why does it take 3 days to diagnose an MI?" So I said, "Well, I'll think about that." And it was true. Traditional teaching was that you did daily measurements of CK, AST, and HBD or LDH. It took 3 days, and could it be done quicker? So I thought about it. I discussed it with Sidney Rizalki. And to this day, we cannot tell you which of us actually came up with the original suggestion. But let's think about how cardiac biomarkers work. Here we have a nice normal cardiac myocyte. Gets a bit ischemic, bit of early infarction, membrane gets a bit leaky, stuff comes out into the blood. And then it infarcts and everything comes out to the blood. And so we have this sort of typical pattern of release of biomarkers. And fundamentally, I'm now going to educate you and make you all fully qualified clinical biochemists in 1 minute. Because in the lab, we measure stuff in the blood. When it changes, something's happening. That's it. Complete education. Right? You're all now fully educated. And this, of course, is what we expect to see. We see a rise progressively up, and it goes above what we describe as the upper limit of normal. And in people that have no heart disease or have angina, levels remain steady and low. Okay, well, they remain steady and low. What happens if you change the scale and do a log plot, for example? Wait a minute, there's a straight line there. Perhaps if we measured the markers more often, we might be able to measure a change, and perhaps we can use that for diagnosis instead. And so the concept of the delta change was born. Rapid serial measurement of biomarkers and determination of the rate of change within the normal range. And we published this in 1988. I haven't been able to find any other paper that actually antecedes the technique we use, which was rapid serial measurement. There are 1 or 2 others that talk about changes over 12 and 24 hours. And we validated it with a subsequent follow-up study looking at CK and CKMB mass and found that they work both very well. And then, of course, the $64,000 question is, if you provide a rapid diagnosis to a clinician, will they act on it? So we did a prospective cohort study where we did what we were doing normally. We shifted over to rapid diagnosis, and then we went back to what we were doing before. And we produced a result that would make every hospital manager delirious with happiness, because we were able to show that the length of stay in hospital dropped from 3 days to 2 days. Now, do remember, this is back in the 80s when people stayed in hospital a long time and we all had enough doctors and nurses and everything else, unlike today. But we were able to show it made a difference. And in fact, interestingly enough, this concept of rapid diagnosis by serial enzyme measurements, like many things invented in the UK, was taken up by the Americans. And in fact, it was the American Emergency Department who utilized this technique for serial measurements and looking at change for diagnosis. And a whole series of papers from Brian Gibler and Jerris Hedges looked at the whole question of using serial measurements. They used CKMB, and they were able to show that they could get people out of their emergency department. Meanwhile, back in the UK, my bosses said to me, "This is marvelous. You must submit this as your doctoral thesis. You've done this really good work. Submit it for your doctorate." So I wrote to the University of Cambridge and it said I wanted to do my doctorate. And this is what I was proposing to do. And this is what they said back to me. Your thesis title into the early diagnosis of myocardial infarction has been rejected as biochemical tests for myocardial infarction do not have a clinical relevance now or for the foreseeable future. There then followed a year's interregnum, after which there was some discussion, and I then submitted my thesis, which was examined by the Regius Professor of Physics, amongst other people, and it was passed without need for any changes, although they did want some confidence intervals put in because that was fashionable at the time. My only regret in life is I didn't actually keep that rejection letter. So what's next in the biomarker saga? It's the advent of troponin. You all know what troponin is. It's part of the cardiac myofiber, and the troponin complex is essentially part of the regulatory system. It's the on-off switch for contraction. And troponin T and troponin I, of course, have unique cardiac sequences, which means we can develop immunoassays for them. And this, of course, again, was a transformation because for the first time in the laboratory, we had a test that was absolutely specific for myocardial injury. Of course, the problem was, how are we going to convince the cardiologists? Because the cardiology community is dominated by the opinion leaders. We didn't have evidence-based medicine at this moment in time, and they weren't interested. They wanted to do an ECG, and that was about it. And in the UK, they wanted to do lots of private practice. So we're going to introduce the new Jedi warrior to cleave aside the evil empire. Well, first of all, Hugo Cattus with his publication in the Journal of Molecular and Cellular Cardiology, which of course is something all of us read every week. But then, of course, we have outbreaks of more interesting publications. And how about troponin as a diagnostic test in AMI? Well, of course, the two things we wanted to know was, does it work? And the second thing, does it make a difference? My colleague who I was working with at the time, Peter Stubbs, he was a great man for saying to me, so what, so what, so what? And it's something you should remember about any test, so what? It's changed, so what? So methodological evaluation, well, you can scan this down. There's the list of the usual suspects down here, from Willy Gerhardt, Hugo Cattus, down to Alan Wu at the bottom. So G to W. And basically, without exception, we looked at this test. It worked. It did what it said on the tin. Clinical evaluation, well, the important thing was the troponin was an outcome predictor. It was a biochemical surrogate of plaque rupture and downstream platelet embolization, so it had potential impact. First demonstrated by Christian Ham, publishing in the New England Journal of Medicine, showing that in patients who are considered to be not myocardial infarction by conventional criteria, that had unstable angina, that they had a much higher event rate. And Peter and I responded at the time in a letter to just after this was published, commenting, troponin T measurements meet the criterion for the best biochemical test for the differential diagnosis of cardiac damage. In combination with measurements of creatine kinase or its MBI enzymes, the dream ticket, allowing the differential diagnosis of chest pain as well as the reliable diagnosis and timing of myocardial infarction. This was while I was a registrar, so before I was a consultant. And subsequently, we published what remains the longest follow-up paper of troponin in patients with unstable angina. We actually did a 5-year follow-up. It was a 5-year follow-up because it actually took us 5 years to get some of the sets of clinical notes back. But out of evil comes good. And we were able to show quite unequivocally that it didn't matter which outcome you looked at, in patients diagnosed as unstable angina by conventional criteria, if you were troponin positive, you died, or you had a heart attack, or you needed to go to the cath lab or then have a bypass. It didn't matter whether you used single or combined events. Basically, troponin worked. And in fact, subsequently, we found that you only needed 100 cases of unstable angina diagnosed by conventional criteria for every troponin method we ever looked at to show that troponin worked and it predicted an adverse outcome. And really, it worked so extremely well because it's cardiospecific. It was exquisitely sensitive because diagnosis using CK or CKMB was flawed, and it occurred in 33% of patients. Always indicates myocardial damage, and it indicates major adverse cardiac events. And in fact, the reason we went on to do our original study is when we were doing our diagnostic evaluation, I was sitting in my office, and I had 3 piles of notes. I had a big pile over here of people that hadn't had an MI, a medium-sized pile over here of people who had had an MI, and then a pile of 4 notes where we couldn't work out what the diagnosis was because they all had an elevated troponin, but they didn't have an MI according to criteria, and we're trying to work out what was wrong. Now, I happened to glance down at the notes, and what was stamped on them? Deceased, 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 deceased. And I turned to Peter and said, do you know those people who didn't work out? They're all dead. He said, oh my God. So that's what we did. So we've got multiple publications now showing that troponin could be used as a single definitive test for acute myocardial infarction, and specific treatments were targeted and related to your troponin status. Low molecular weight heparin only works if you're troponin positive. Revascularization only works if you're troponin positive. Glycoprotein 2B3 antagonists only work if you're troponin positive. So, fantastic. And there were sufficient publications to allow a meta-analysis and a subsequent HTA, and even to convince the Scots, who are the most notorious non-spenders of money. And this was their health technology assessment report, and they said, you shall measure troponin. So, troponin is it. So the 90s really is the troponin decade, with the first recognition of troponin in heart injury, troponin T, troponin I for MI, risk stratification, and then finally the NACB troponin guidelines. What else happened in the 90s, I wonder? This company popped up on the scene. You may recognize them. Little Finnish company started producing extremely good science and apparently made money as well. Well done. So, of course, the apotheosis of troponin comes really following the NACB guidelines with the consensus statement from the European Society of Cardiology and the American College of Cardiology. Myocardial infarction redefined a consensus document of the Joint European Society guidelines that basically said, thou shalt measure troponin, nothing but troponin, and troponin shall be what you shall use to manage patients. So this was really a transformation. And of course, this has gone on. Not only did troponin take over America and Europe, but it then went on to take over the world with the universal definition of myocardial infarction. Although we're, of course, like many things in the world, it takes a little time, so we're now on the 3rd universal definition of myocardial infarction, largely because the interventionists are arguing, as usual. And basically, here we have it. Acute myocardial infarction means the evidence of myocardial necrosis with a rise and fall of cardiac biomarker values, preferably troponin, and at least one above the 9th percentile, and symptoms of ischemia, ECG changes, imaging changes, or evidence of a thrombus at angiography or autopsy. And this is actually a very, very good definition of MI, type 1, alas. Troponin is in the guidelines. It is part of your management algorithm. Come in with chest pain, do an ECG, do the troponin. Is it rising and falling, or is it normal? This tells you where to go. So it's there. It is the test. Unfortunately, though, we become victims of our own success, and it's quite interesting historically to look back and see why this was the case. When I was introducing troponin into my own laboratory, it would cost 30 euros a test. We were currently measuring CK, that would cost about 50 cents. So, of course, I rang up the hospital administrator and I said to him, I've got this great new test for diagnosing heart attacks. It'll cost 30 euros and it'll replace a test that costs 50 cents. What did he say to me? Paul, that's marvellous. Can I give you some more money? No. They didn't do that. They went, ha ha ha. So we had to convince everybody this was a much better test. So we said to everybody, it's easy. You do it once at 12 hours. If it's negative, send the patient home. Don't have to do anything else. Don't have to keep them in for 3 days. And they all went, yeah, that'll save money. We'll do that. We'll do an audit first. So they came in and they sat in, the people from public health came and sat in our emergency department, making a note of who was coming in. They said, do you know that patients with chest pain are the most common admission to this hospital? We said, no, really? And they said, here's the money. Done. But of course, this meant that basically everyone got in their mind, troponin, heart attack. So we're victims of our own success. And in fact, as a large number of troponin estimations are done inappropriately. Perhaps they're not done in Finland, but they certainly are in the UK. And of course, there are a large number of causes of troponin elevation which are not due to an acute coronary syndrome, something that we recognized early on, but we've been trying to educate people. So we get this problem.
Hi.
Hi.
Are you the cardiologist on call?
Yes. Who are you?
This is the emergency department.
Sure. What's the story?
There is a troponin. You need to fix it.
Okay. Tell me more.
There is a troponin. You need to fix it.
Can you tell me more?
The troponin is 0.3. You need to fix it.
Okay. Let's start from the basics. Where is the patient?
We moved her to the cath lab. You need to fix it.
Anything else you can tell me?
The troponin belongs to a 97-year-old lady from a nursing home. She is fasted. That is good.
Any comorbidities?
She is otherwise well. Except for...
Except for what?
Her temperature is 29 degrees.
Right.
And her pH is 6.8.
Really?
And she has a condition I have not seen before.
Which condition is that?
A systole.
A systole.
A systole.
Right. And you want me to catheterize her?
There is a troponin. You need to fix it.
Why didn't you tell me about it from the start?
I did. There is a troponin. You need to fix it.
No, not the goddamn troponin, the bit about a systole.
Because then you might refuse to catheterize her.
Don't you think I'd have noticed a systole when the patient arrived in the cath lab?
It will not take you long to fix the troponin. You are very skilled with needles and contrast injection.
She is not fit enough for a haircut, let alone in catheterization.
There will be minimal door to balloon time.
I think she has other management priorities at the moment.
Like the troponin.
Like CPR.
They have finished doing that.
Oh. They have stopped doing CPR on someone in a systole.
Yes.
That means she is dead.
There will be minimal blood loss.
You know what? You're right. There is not much blood loss when there's no friggin' cardiac output.
You need to fix the troponin.
Please go away.
You are being obstructive by refusing to do my case.
And you are making my head hurt.
There is a troponin. You need to fix it.
I need to go and run into a brick wall.
If you have chest pain, I will consult cardiology for you.
The fact of the matter is that although that appears flippant, it's happening all the time in emergency departments around the world. There's a troponin. You need to fix it. So there we are now. So what's the future? What's the troponin future? Well, we've actually got the advent of sensitive troponin assays, which of course are assays that we do with love, care and delicacy, rather than the old-fashioned ones. And we've got rapid diagnosis by point-of-care testing. So the new concept, of course, for sensitive troponin is rapid serial measurements for the determination of rate of change within the normal interval. Where have I heard that before? We do have one thing that's actually really new, which of course is troponin as a prognostic marker in the apparently healthy, and this really is quite exciting work. We have point-of-care testing. This was one of the randomized controlled trial that we did, looking at the impact of point-of-care testing in the emergency department. One of my cardiology colleagues read this, Jim Januzzi, and he said, "Paul, I've got to congratulate you on that trial." I said, "Oh, thanks, Jim, that's very nice." He said, "That's the best acronym I've ever seen." Thanks, Jim. And basically, this was a fairly straightforward trial. You came into the emergency department, you got randomized to kind of conventional care, or you had biomarkers measured at 0 and 90 minutes. And we said, how quickly can you get out of hospital, and do you die? And the net result was you did actually get out of hospital really quite quickly. It really shortened the length of stay quite dramatically. Nobody died, but it did cost a little bit more money because more people went into the CCU, which is actually probably appropriate use of resources. But it's the first randomized controlled trial. Was one of the few randomized controlled trials in diagnostics. It was the first to demonstrate a positive outcome. So our cardiac timeline is pretty much complete. We've gone all the way through from nothing, AST, troponin, and troponin standardization. And of course, this has been accompanied by all the work from HyTest as well, which has been a massive contribution to the whole area. It's always been a great pleasure whenever I'm a referee for clinical chemistry. And when I see Peterson as one of the co-authors, I go, "Oh, good, this will be really worth reading." Because the work that's come out has been, and I'm sorry Alexei isn't here either, because he's one of the other guys, so I've always enjoyed reading their studies because they've made a tremendous contribution. And HyTest, I hope, will be around in another 20 years, although I might not be. So I'd like to give thanks to a number of people over the years who've been co-workers. Marcus Flather originally, who's now a professor in the east of England, who was one of my initial co-workers. Whole load of people, and of course the lab staff everywhere I've ever worked. I've got some principal friends. Sidney Rozalki, who really was my mentor and inspirer in this work. Richard Fink, my first boss, who supported me. Peter Stubbs, who sadly died, who was a cardiologist, sadly died of a heart attack, who was my collaborator and one of my best friends. David Gaze, who some of you might have met, who's my auxiliary brain in this matter. Steve Goodacre, who's been instrumental in collaboration. Of course, my family, who've put up with my idiosyncrasy, and my daughter saying to my wife, "Is Daddy ever in the country?" We'll finish with a nice grey reef shark and just a few thoughts at the end. My thanks to HyTest, obviously. I'm very grateful and very honoured to receive this award. Everyone asks me, what are you going to do with it? So I thought I'd share my thoughts. There's an obvious thought, but I'm not that menopausal yet. So I've decided what I'm going to spend it on. I'm going to spend it on young women and alcohol. Here they are. These are the biochemists who work in our lab, and they've all been set a challenge. Anyone who gets an abstract accepted to the AACC will have their flight and registration paid for. There's the alcohol, as you can see, ready for them to do some chromatographic separation. So, at that point, I will say, oh, and perhaps spend it on some of that. And does anybody have any questions?